everyone, and welcome to the July 2026 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania. And we're your co-hosts for this podcast series.
So for those of you who attended the 86th ADA Scientific Sessions in New Orleans, welcome back. I hope you have recovered from the busyness of the sessions and returned with renewed inspiration and learnings. I know that for me, this ADA showcased exciting science and innovations, but most importantly, it was a reminder that the scientific diabetes community is a strong family and stands with each other, and the opportunity to discuss and exchange ideas freely and openly are critical to its ongoing success.
And the scientific program was created by 34 members of the Scientific Sessions Planning Committee that was led by Dr. Mark Atkinsons. And what a superb job they did putting this together for us all. And I want to extend my congratulations and gratitude to them for all of their hard work.
And for those who want to listen to sessions that you were not able to attend or want to revisit a session that was particularly interesting, remember that attendees can access recordings from the 2026 scientific sessions at ada2026.org through August 10th, 2026. And even if you did not register this year, non-registrants may still purchase on-demand access through August 7th, with all recordings available for viewing through to August 10th. Eligible attendees can also claim continuing education credits at ada2026.org. That's ada2026.org for details, and you can access as well as get CE information.
Also, as we did in previous years, the hosts from all of the ADA's podcasts assembled in front of a live audience for a special episode recapping some of the key highlights from scientific sessions, including the ADA's newest podcast, The Points of Care, which is a companion to the journal Diabetes, Obesity, and Cardiometabolic Care. Check out that episode when you get a chance.
And before we get to our interviews, Mike, are you ready for the question of the month?
Okay, hit me, Alice.
All right, so if you could go back in time and talk to yourself as a first-year medical student, what would you tell young Mike Rickles?
So this is a little bit easier for me since I try to do this when I do talk to first-year medical students. And the advice, which I think I did a pretty reasonable job following myself, is to keep an open mind. And by that, I mean with each topic that you encounter, take advantage of the opportunity to really dive in deep, because whether you believe you're not going to be interested in this specialty, it might amaze you what you learn about it. But also, even when you end up in another specialty, you're going to carry forward those learnings from that intensive study of that system or that field for the rest of your career. And you won't have another opportunity to really get that type of intensive instruction.
It's good advice. Good advice. I think for myself, it would actually be along those lines. And I think I would tell myself that A, everything's going to be fine, and that everything does, in fact, work out in the end, as corny as that may sound. And along those lines, it's the idea that you should follow whatever it is that you feel that you want to do, even if it's not necessarily the path that others may have envisioned for you. And at the end of the day, you have to love what it is that you do. And sometimes opportunities open up. So take them and run with them and sort of see what happens. But the path is never straight, is it? The path is always round circles and sometimes backwards and sometimes forwards. But at the end of the day, it's all going to be fine. I think that's probably what I would tell myself.
Well, on that note, why don't we launch into the July 2026 episode of Diabetes Care on Air? Alice and I will each conduct an interview with authors of feature articles as per usual, and that'll be followed by our rapid exchange segment where we'll each pick 3 articles of particular interest to us.
And with that, let the learning begin.
In the July 2026 issue of Diabetes Care is a feature article entitled Continuous Glucose Monitoring and Mortality Risk Among U.S. Veteran Dialysis Patients with Diabetes. I'm delighted we have joining us the article's senior author, Dr. Connie Rhee. Dr. Rhee is professor of medicine at the University of California, Los Angeles, and chief of nephrology at the VA Greater Los Angeles Healthcare System. Welcome, Connie.
Thank you. It's a pleasure to be here. On behalf of my co-authors, I'd like to thank Diabetes Care for the opportunity to discuss our study examining continuous glucose monitoring use and mortality risk among U.S. veterans with diabetes receiving dialysis.
And congratulations to you, Connie, and to your co-authors on this feature article. I'd like to start our discussion with the problem of dysglycemia in our patients with diabetes and end-stage kidney disease who are receiving dialysis. Can you take us through the unique mechanisms that can increase risk for both hypoglycemia and hyperglycemia in this population?
Thank you for this important question. This is a critical point to highlight given that population-based studies show that people with diabetes with coexisting CKD have a higher risk of dysglycemia than those without CKD. Patients with diabetes and end-stage kidney disease are at heightened risk for hypoglycemia through multiple pathways, including impaired insulin degradation and clearance, impaired hepatic clearance of insulin, decreased kidney gluconeogenesis, coexisting comorbidities that are prevalent in ESKD, such as protein energy wasting and diabetic gastroparesis, limited in-center hemodialysis food access, as well as intradialytic glucose shifts. But conversely, they are also susceptible to hyperglycemia due to reduced insulin secretion, exposure to high glucose dialysis solutions, particularly in peritoneal dialysis, and impaired insulin sensitivity.
So, with all of those risks setting up both challenges faced with hypoglycemia and hyperglycemia, there have also historically been challenges with the assessment of glycemic control for individuals with diabetes on dialysis. Can you now take us through some of the limitations of using more traditional metrics of glycemic control in those receiving dialysis?
Traditionally, hemoglobin A1C has been the cornerstone for assessing glycemic control, but it has important limitations in dialysis patients. First, hemoglobin A1C may be less accurate in end-stage kidney disease because of derangements in the factors that influence the non-enzymatic reaction between glucose and the hemoglobin beta chain. This includes metabolic acidosis and elevated BUN levels that may overestimate true glycemic exposure, or conversely, anemia, erythropoiesis stimulating agents, blood transfusions, and any factor that shortens the red blood cell lifespan, including the dialysis procedure in and of itself, may underestimate true glycemic exposure. Furthermore, hemoglobin A1C reflects average glucose exposure over several months, but it does not provide information about glucose variability, hypoglycemia, or time spent within target range. Next, fingerstick glucose monitoring provides only isolated snapshots and can miss clinically important fluctuations throughout the day and night in dialysis patients. And thirdly, while there has been increasing interest in glycated albumin and fructosamine as intermediate markers of glycemic control, given that they are not influenced by hemoglobin level nor erythropoiesis, they may also be inaccurate in altered serum protein states, which are prevalent in dialysis patients. So together, these limitations have created a major unmet need for more comprehensive approaches for glucose assessment in this population.
Yeah, and we've all faced those challenges in understanding glycemia and the burden of diabetes management in our patients on hemodialysis. And so that really brings us now to the crux of your paper, which is to look at continuous glucose monitoring or CGM in this population. And so, Connie, can you tell us what was known about CGM in individuals with diabetes on dialysis before your study? And what were the primary questions you were seeking to understand?
Prior studies have shown that CGM provides a much more detailed picture of glycemic patterns in patients receiving dialysis. Investigators have demonstrated that high rates of unrecognized hypoglycemia, substantial glycemic variability, and important differences in glucose patterns on dialysis days are observed versus non-dialysis days. A growing number of studies have also shown acceptable clinical agreement between CGM interstitial glucose and blood glucose values. However, most prior studies were relatively small and/or were focused on glucose metrics rather than clinical outcomes. What remained unknown was whether CGM use translates into better patient outcomes. Specifically, no large studies have examined whether CGM use was associated with lower mortality risk among patients receiving dialysis. Thus, our goal was to address this knowledge gap by evaluating the association between CGM use and all-cause mortality in a national cohort of U.S. veterans with diabetes receiving dialysis.
So, Connie, you're all about go big or go home. So you went right for the most important outcome. And your primary analytic sample included 1,544 propensity match pairs of CGM users and non-users that included over 5,000 person years of follow-up. And so with all of that accumulated data, what did your analysis find?
Our study found that CGM use was associated with a substantially lower risk of death after carefully matching CGM users and non-CGM users on a broad range of demographic, clinical, laboratory, and treatment characteristics using propensity scores. De novo or incident CGM users experience approximately a 29% lower risk of all-cause mortality compared with non-users. Importantly, the findings were consistent across multiple sensitivity analyses, which strengthen our confidence in the robustness of the results. While this was an observational study and cannot establish causality, the magnitude and consistency of the association were notable and suggest that CGM may offer clinically meaningful benefits in this high-risk population.
Absolutely. And what you also point out in the analysis in your paper, Connie, is that the number needed to treat with CGM for 2 years, over a 2-year period, to prevent one death in this population was 28. So it seems to me that all of our patients with diabetes on dialysis should be provided CGM. There aren't too many other interventions that can have such an important impact on mortality. And so for those of us that hopefully can get more of our patients with diabetes on dialysis to use CGM, are there concerns with CGM sensor accuracy, either during dialysis sessions, with hemodialysis that constitute the vast majority of your study cohort, or with peritoneal dialysis? Are there issues that we should be tuned into in advising our patients?
That's an excellent question. Overall, the available evidence suggests that modern CGM systems perform reasonably well in patients receiving dialysis, although some limitations remain. During hemodialysis, theoretically, rapid fluid shifts could potentially contribute to differences between interstitial and blood glucose and affect sensor performance, particularly during periods of rapidly changing glucose levels. However, recent studies have generally shown acceptable clinical accuracy for contemporary CGM devices. For peritoneal dialysis, there has been some concern that glucose absorption from dialysis solutions could influence glycemic patterns, but CGM remains valuable for detecting these fluctuations. I think it's important to emphasize that no monitoring tool is perfect. The key point is that CGM provides substantially more information than either hemoglobin A1C or intermittent fingerstick testing and allows clinicians and patients to identify patterns that would otherwise go unnoticed.
And so for all of the challenges with other forms of monitoring glycemia for our patients with diabetes, it seems that while there can be moments and limitations of CGM, that it really is so much more helpful and accurate, and now showing that the real mortality benefit in users, that certainly I'm sure you're interested in understanding more about how that might work. And in the meantime, we should all hopefully be getting more access to CGM for our patients. But I want to ask you about mechanism. And I know that your current study was not designed to address mechanism, but I'm interested to hear, Connie, how you hypothesize CGM might be working to reduce mortality risk in this population, and what further studies might be needed.
That is correct that our study was not designed to determine mechanisms, but there are several possible pathways. First, CGM may reduce severe hypoglycemia by providing real-time alerts and allowing earlier intervention. Hypoglycemia has been linked to arrhythmias, cardiovascular events, falls, hospitalizations, and death, which is prevalent in dialysis patients. Second, CGM may improve overall glycemic management by helping patients and clinicians make more informed, personalized treatment decisions. Better control of both hyperglycemia and glycemic variability could potentially reduce these complications. Third, CGM may enhance patient engagement and self-management. Patients gain immediate feedback regarding how meals, medications, dialysis sessions, and physical activity affect their glucose levels. Finally, CGM data may facilitate more individualized treatment plans and medication adjustments. The next critical step from here is conducting randomized controlled trials to determine whether CGM directly improves survival and other patient-centered outcomes such as hospitalizations, severe hypoglycemia, cardiovascular events, and quality of life in dialysis populations.
That's wonderful, Connie. And are there any additional points or takeaway messages that you'd like to make for our listeners?
I would like to highlight three key messages. First, patients with diabetes receiving dialysis are among the most medically complex and vulnerable individuals we care for, and traditional approaches to glycemic assessment have important limitations in this population. Second, our study found that CGM use was associated with a significantly lower risk of death in a large national cohort of veterans receiving dialysis. And third, while additional randomized controlled trials are needed, these findings support growing consideration of CGM as an important component of diabetes management in patients with end-stage kidney disease. Ultimately, CGM provides a more complete picture of glucose health, and that information may help patients and clinicians make better decisions and potentially improve outcomes.
Well, I so appreciate what your study has done to really shine the light on the importance of applying advanced diabetes technologies to this vulnerable population of patients with diabetes on dialysis. Dr. Connie Rhee, thank you so much for sharing your expertise with us today. I really am so glad for all I've learned from your article, our discussion, and the elucidation of mortality benefit observed with CGM use in individuals with diabetes and end-stage kidney disease receiving dialysis. I want to encourage all our listeners to access the full article in the July 2026 issue of Diabetes Care.
One of the feature articles from the July 2026 issue of Diabetes Care is a retrospective study entitled Differences in Clinical Manifestations in Islet Autoantibodies by Age in Adult-Onset Type 1 Diabetes by Dr. Kagan Karakis and colleagues from the Barbara Davis Center for Diabetes in Colorado, United States. I'm joined today by the senior author, Dr. Erin Michels, endocrinologist, physician scientist, and professor of medicine from the Barbara Davis Center for Diabetes, University of Colorado. Thank you for agreeing to be part of this podcast, Erin, and congratulations to you and your colleagues for this meaningful publication.
Thank you so much for that kind introduction. It's really an honor to be part of this podcast today, and I'm delighted to have the opportunity to discuss our work and share our findings with you and the audience.
That's great. So, Erin, let's just dive right in. So, why was this retrospective study conducted? What question or questions were you trying to answer?
Yes, so we conducted this study because adult onset type 1 diabetes, it's actually quite common and increasing, but it's not as well understood as childhood onset disease. And so the questions we wanted to address were, we really wanted to know whether adults differed in their clinical presentation, islet autoantibody profiles, and genetics compared to children that present with new onset type 1 diabetes.
Those are important questions to answer because I got to say, as a clinician, I'm definitely seeing adults being diagnosed with type 1 diabetes. And my understanding is more than half of new diagnoses of type 1 typically occur after the age of 18. So, an important group to characterize. So, how did you go about answering those questions?
So what we did was look at a really large group of people with newly diagnosed type 1 diabetes at our center, the Barbara Davis Center for Diabetes. It's a large tertiary referral center in Colorado. And over the last 3 decades, that amounted to just over 400 adults and 200 children with new onset type 1 diabetes. And so we compared their clinical presentation, laboratory findings, and genetic markers. Specifically, we really wanted to look at the four major islet autoantibodies and human leukocyte antigen genes, which do confer risk for type 1 diabetes, to better understand biologic differences between adults and children with type 1 diabetes.
So, let's start off with the clinical characteristics then of adult new onset stage 3 type 1 diabetes. So, what were some of your findings?
So the first one I want to bring up is it's quite remarkable, but adults can really develop type 1 diabetes at any age. And we had a good number of adults over the age of 40 and even up to the age of 76 years that presented with new onset type 1 diabetes. But adults were a lot less likely to present diabetic ketoacidosis compared to children, even though they had high blood sugar levels, elevated hemoglobin A1Cs. DKA was just a lot less in adults compared to children. And so the adult presentation, it was less severe, more gradual, and especially those that were diagnosed over the age of 40. And just one kind of numerical fact I want to point out, only 11% of adults over the age of 40 presented in diabetic ketoacidosis, which is great. This is a life-threatening condition, and that's compared to about 55% of children that presented with DKA in our cohort, but it also makes diagnosis a little more challenging in adults, especially as they increase in age.
Yeah, so misdiagnosis in adults with new onset diabetes, I guess, is a very real thing. And I think your data really show why that might happen because they're not presenting in the classic in hospital DKA kind of picture. Now, let's talk about the islet autoantibodies because that's what we would fall back on is to say, okay, I wonder if this could be type 1. Let me order islet autoantibodies. So, how did adult new onset differ from the pediatric cohort?
Yeah, so first we did measure the four major islet autoantibodies, those directed towards insulin, glutamic acid decarboxylase, islet antigen 2, and zinc transporter 8 in almost our entire cohort, which is, I think, a real strength. And so what we found were adults were more likely to have fewer of the four islet autoantibodies, or even none compared to children. Antibodies are a great marker in children, and the vast majority had antibodies and multiple antibodies at presentation. However, adults, it was roughly 15% did not have antibodies, and then another 30% only had a single antibody. And most often, that single antibody was directed to GAD, glutamic acid decarboxylase. But interestingly, there were a good number of adults that also had a single insulin antibody, IA2 antibody, or zinc transporter 8 antibody. And I think that just highlights the importance of using islet antibodies as a diagnostic marker and trying to measure more than just a single antibody to GAD to help make a diagnosis of type 1 diabetes.
What struck me with what you just said, though, was that 15%, if I heard you correctly, 15% of the adult group had zero islet autoantibodies, of the ones that we routinely check for, or can check for, I should say. So, anything special about that group? I mean, I'm going to ask you perhaps a dumb question. Are we actually sure they had type 1 diabetes?
Yeah, so these are excellent questions and ones that we had, and obviously even reviewers of the manuscript, because were we just wrong? Do these people have high blood sugar, but is it very likely type 2 diabetes? But that group that had no antibodies, which was again fairly sizable, 15% of a little over 400 people. So what they looked like, they had normal to just mildly elevated body mass indexes. They definitely had elevated hemoglobin A1C levels. This was diabetes, and they required insulin treatment at their presentation. And I think that's really, really what helped us. But I think all of this highlights that diagnosis of diabetes type in adults, it's complex. I really love islet autoantibody testing, but sometimes we have to look beyond that. And kind of as a future direction, I think we really need other markers that help us distinguish type of diabetes in adults or mark autoimmunity.
Were C peptides ordered in that group so that, again, helping to confirm the diagnosis?
Great question. So C-peptide was measured in a good good chunk of our patients, especially those with 0 and 1 antibody. And the vast majority, I believe it was roughly 80%, had undetectable low or even normal C-peptide despite high blood sugar levels, which again would indicate insulin deficiency and likely type 1 diabetes. So C-peptide measurements in that setting can be very helpful.
So then how about the presence of high risk HLA alleles? Any difference there?
So really overall adults and children, they had similar genetic risk, meaning their underlying genetic predisposition for type 1 diabetes was pretty much shared across the ages. And this just kind of tells me, since the clinical presentation differs, the genetic foundation is still the same and important in adults. It's not that they had less of these high risk human leukocyte antigen alleles. It was very, very comparable to children.
Okay, thank you. So, what are the key clinical implications then of what you and your group found?
Yeah, so first, I really want to highlight that type 1 diabetes can really develop at any age. In this large cohort, we had 1-year-olds and all the way out to 76 years old in our study. And so I really, type 1 diabetes is a disease of children and adults, not just children anymore. And then the second takeaway is that type 1 diabetes presentation in adults, it looks different. And as we mentioned earlier, it can be misdiagnosed as type 2 diabetes quite frequently. And the clinical presentation does seem to change with age in terms of blood glucose level, rates of DKA, and I think recognizing these differences hopefully helps healthcare providers diagnose type 1 diabetes, start insulin sooner, which obviously improves overall outcomes.
And finally, where do you go from here? What are the remaining unanswered questions?
Yeah, so obviously, I think the study was really, really helpful to look at adults with type 1 diabetes, but like all good research, there's more questions. So, really, we need better markers to diagnose type 1 diabetes in adults, whether that is a C-peptide, metabolic markers, another antibody. I think all of us were a little shocked at the sheer number of adults that had no antibodies or even just one antibody. And so some of our future work will be to try to identify a marker or markers that help diagnose type 1 diabetes in adults, which then should hopefully improve earlier detection and help understand the natural history of type 1 diabetes in adults. I think we really want to know how the disease progresses before, adults present with hyperglycemia and need insulin treatment, which can definitely aid screening and prevention of diabetes in adults.
Well, thank you very much, Dr. Erin Michels, for sharing your expertise with us today. Congratulations to you and your colleagues for contributing to our knowledge base on this important topic. And as you said, many adults with new onset stage 3 type 1 diabetes are misdiagnosed as living with type 2 diabetes. And I think having a better understanding of how they present and how that differs from our traditional teaching will help to lessen that occurrence. And I think a big takeaway that I'm going to have is just to raise my index of suspicion and to not assume that every person newly presenting with hyperglycemia who happens to be an adult is automatically living with type 2 diabetes, but could be type 1, and not let age be a barrier to me actually making the right diagnosis. But I got to say that 15% zero islet autoantibodies throws me off. So then we fall back on our clinical expertise and think about, okay, is insulin appropriate in this individual? But I look forward to watching this field continue to evolve. So thanks again, Erin. And I encourage our listeners to read the full article in the July 2026 issue of Diabetes Care. Let's move on now to the Rapid Exchange segment, where Mike and I will discuss articles we found of particular interest this month. Mike, what is your first pick?
Thanks, Alice. My picks today will follow a continuum along the course of type 1 diabetes. And my first pick evaluates age-related increase in hemoglobin A1C to more accurately quantify risk of progression to clinical stage 3 type 1 diabetes among islet autoantibody positive adults. Dr. Aaron Templeman from Exeter in the United Kingdom and colleagues analyzed over 5,000 autoantibody positive individuals in the TrialNet Pathway to Prevention study and modeled hemoglobin A1C effects against those from over 6,000 adults included in an Exeter-based population cohort. Autoantibody positive children with a hemoglobin A1C at or above 5.7 percentage points had higher risk of progression to clinical diabetes than adults using the same hemoglobin A1C threshold. And that was especially true for adults above the age of 30 years. However, this difference in hemoglobin A1C threshold and risk of progression to clinical diabetes was attenuated when the authors adjusted for age. And when the authors applied instead a hemoglobin A1C threshold of greater than or equal to 6 percentage points, both children and adults had comparable risk of progression to clinical diabetes. And so these findings suggest that age-related variation in hemoglobin A1C should influence classification of dysglycemia for autoantibody positive adults, perhaps considering a threshold of 6% or greater in individuals over the age of 30 years.
It's been fun watching this field evolve over time as we're getting a better understanding of who to screen, how to screen, and not just screen, but how to monitor. And I think this is very helpful information to help guide that monitoring, because that monitoring could be over the course of years. So having a better understanding of who do we need to be more worried about and maybe help guide when do we check more frequently, I think all of this information really helps to guide that. So thank you for that, Mike. For this episode, I actually don't think I have a theme when I think about the picks that I ended up choosing, but maybe at the end, the listeners can decide if there actually ended up being a theme. So my first pick addresses the question of whether a multi-component precision medicine intervention among individuals with young onset type 2 diabetes could reduce diabetes-related complications or cardiometabolic status. So Professor Andrea Look and colleagues from the Chinese University of Hong Kong conducted a randomized controlled trial of 884 Chinese participants with young onset non-type 1 diabetes. They were randomized to either the JADE Prism or JADE only groups. So what is that? The JADE Prism group received a 3-year intervention program. In year 1, they were followed at a diabetes center for intensified management, including structured assessment guided by the web-based JADE platform, testing for anti-GAD antibodies, fasting C-peptide, targeted exome sequencing for pathogenic variants in 34 monogenic diabetes genes, and genome-wide genotyping, as well as completion of validated questionnaires to assess quality of life and emotional well-being. Participants were assessed by the diabetes team every 3 months with adjustment of therapies guided by biogenetic information and treatment algorithms to attain multiple targets. After year 1, the JADE Prism group returned to their original care with annual review by the diabetes team. In contrast, the JADE only group received a JADE report at randomization, which did not include biogenetic testing, and their diabetes was managed in their usual clinics per local treatment guidelines. After the 3-year intervention, there was no difference between the groups for the primary endpoint of incident or progression of all diabetes-related complications. However, significantly more of the JADE Prism group attained 3 or more treatment targets. So it was 24% versus about 12%, with improved markers of beta cell function and reduced emotional distress, but more medications were utilized. So it appears that this multi-component precision medicine intervention, utilizing biogenetic information to guide treatment decisions, resulted in improved cardiometabolic status. Complications, however, were not reduced, but I wonder if that is simply a function of not enough time to actually show a difference.
I agree, Alice. It would be great if this cohort could be retained for longer term follow-up. The makeup of the study participants really highlights the heterogeneity of diabetes that presents in younger age individuals. My next pick looks at early treatment of type 1 diabetes with low-dose antithymocyte globulin, or ATG, that's been applied for disease-modifying therapy. Dr. David Weber and colleagues from the University of Florida in Gainesville analyzed a modified quantitative response, or MQR, of C-peptide data derived from 22 individuals treated clinically with ATG for either stage 2 or stage 3 type 1 diabetes who had 1-year follow-up. The MQR is calculated from the C-peptide concentration at 90 minutes following ingestion of a standardized boost mixed meal tolerance test. Importantly, over 2/3 of those treated with ATG in this cohort demonstrated preservation of the MQR. So these are real world results that are consistent with those reported from randomized clinical trials involving ATG. And here, use of a single post meal challenge blood draw for quantifying stimulated C peptide should really aid the feasibility for assessment of islet function in clinical practice. Now, it's notable that in the islet transplant community, this 90-minute boost high protein glucose and C-peptide measurements have been used to assess transplant islet function for over 2 decades. And so I really was no surprise to me that this simplified stimulation test should also work well for assessing preservation of islet function following early intervention with disease modifying therapy in type 1 diabetes.
It's always nice to see when we learn from other areas, right, within medicine, because there's usually no need to reinvent the wheel if there's a test that has been effective in a slightly different area. But just out of curiosity, Mike, because I know that you're involved in transplant, have you ever tasted the Boost high protein?
I have, Alice, and sometimes when I'm working late and I'm hungry, and it saves me a trip to find a vending machine somewhere when it's late in the hospital, I'll go to our stock of Boost High Protein in the research office next door.
I have no doubt. I'm sure every single person listening who has ever done an on-call shift has undoubtedly taken food from somewhere. Sorry, I thought I would just ask you that. All right, so my second pick carries on from a study that I actually chatted about back in September 2025. At that time, Mr. Henrik Magnussen and colleagues from the University of Copenhagen in Denmark determined that SGLT2 inhibitor was able to increase urinary glucose excretion in those living with HNF1 alpha MODY, aka MODY3. This was an important finding because MODY3 is typically treated with sulfonylurea followed by insulin, and it was thought that SGLT2 inhibitor would not be effective because of decreased expression of the gene encoding SGLT2 based on knockout mouse and human kidney cell models. In the July 2026 issue of Diabetes Care, Mr. Henrik Magnussen and colleagues from the University of Copenhagen took this question to the next level and published a randomized, double-blind, placebo-controlled crossover trial of empagliflozin, 25 milligrams, in 18 participants with HNF1 alpha MODY. The participants were all on at least one glucose-lowering drug and were randomized to 4 weeks of daily empagliflozin 25 milligrams, followed by a 2-week washout period, and then placebo daily for 4 weeks, or the opposite sequence. The primary outcome was mean glucose assessed by 10 days of continuous glucose monitoring. Compared with placebo, empagliflozin lowered mean glucose by 2.3 millimoles per liter, or 41 milligrams per deciliter. There were no significant differences in hypoglycemia outcomes or unexpected adverse effects. So this now provides an additional effective option for the treatment of HNF1 alpha MODY.
And that effect size for glucose lowering by empagliflozin in HNF1A MODY is really quite extraordinary, and makes me imagine that better understanding how that's happening in this specific form of monogenic diabetes could help reveal some of the still unresolved mysteries regarding the metabolic mechanisms impacted by SGLT2 inhibition. Now, my final pick examines the prevalence of impaired awareness of hypoglycemia in youth with type 1 diabetes over the past 2 decades. Mr. Peter Delaney from Netherlands, Australia, and colleagues analyzed an online survey completed by over 400 youth ages 12 to 18 years that was conducted in 2024 and compared to results from cohorts previously assessed in 2015 and 2002. Close to 100% of the current cohort used continuous glucose monitoring, and almost half were using automated insulin delivery. The prevalence of impaired awareness of hypoglycemia in the current cohort was 16%, and that's compared to 21% and 33% in each of the previous cohorts. And the severe hypoglycemia rate was reported at 0.92 events per 100 patient years in the current cohort, which is a 3.5-fold reduction and 30-fold reduction from rates in each of the previous cohorts. So this is really great news for severe hypoglycemia prevalence among youth with type 1 diabetes. However, impaired awareness of hypoglycemia remains prevalent and could carry forward more problems with defense against hypoglycemia into adulthood.
And you're right. I mean, it's good news to see that the rates have definitely gone down, right? It's gone down between those time points that you mentioned, and it's probably a function of the therapies that we're able to offer, the insulins that we're able to offer, the likelihood of experiencing hypoglycemia, et cetera. However, you make a very valid point that it's not zero. So there is definitely still work to be done to continue to help these individuals. And I look forward to the next time this is looked at, because it looks like it's roughly a 10-year time point. So maybe in 2034, we'll be able to report. Don't know if it'll be you and me, Mike, per se, but somebody will be able to report what that survey ends up showing. So my third pick assessed whether COVID-19 vaccination was associated with the risk of type 1 diabetes and whether COVID-19 vaccination or infection were associated with diabetes severity at T1D diagnosis. The rationale for the study was that after the beginning of the COVID-19 pandemic, the incidence rate of type 1 diabetes increased during the lockdowns, and the symptoms at diagnosis were more severe. Therefore, there was a question as to whether COVID-19 infection and or vaccinations may have played a role in what was observed. Dr. Susanna Tall and colleagues from Helsinki, Finland, performed a case control study to try to answer those questions. Using the Finnish Pediatric Diabetes Register, they identified 433 children, ages 5 to 14 years, that were diagnosed with type 1 diabetes between September 2021 and December 2022. Each case subject was matched with 3 control subjects for age, sex, and municipality. They found that a similar proportion of both case and control subjects received at least one vaccination at 36% and 33%, respectively. 2 or more vaccinations also were not associated with the risk of type 1 diabetes. Children who had received at least one COVID-19 vaccination before their type 1 diabetes diagnosis actually had a lower risk for DKA, lower plasma glucose, and beta hydroxybutyrate at diagnosis compared to those who had not received vaccination. Now, this is likely due to an indirect effect, reflecting parents who chose to vaccinate their children may be more likely to seek medical care. There was no association between SARS-CoV-2 infections and metabolic decompensation, including pH, DKA, severe DKA, glucose, beta hydroxybutyrate, and A1C at diagnosis. They also had a couple of other observations that were difficult to explain. COVID-19 vaccination was associated with an overrepresentation of some protective HLA genotypes and also associated with lower prevalence of insulin antigen antibodies at diagnosis. These findings were unexpected and difficult to correlate. Bottom line, this case control study suggests that neither COVID-19 vaccination nor SARS-CoV-2 infections explain the increased incidence of T1D or the increased severity at diagnosis that was observed in Finland at the beginning of the pandemic.
Those are certainly reassuring data, Alice, and also important to share since COVID-19 vaccination continues to be important for lowering severity of acquired infections. And so for those who are eligible, updating your COVID-19 vaccine each year provides ongoing protection that reduces the risk of emergency department visits, hospitalizations, and critical illness. Well, this brings us to the end of the July 2026 episode of Diabetes Care on Air. And a big thank you to Drs. Erin Michels and Connie Rhee for sharing their expertise with us.
Reminder to all that Diabetes Care Journal is continuing to take submissions of original art for consideration to be included on a future journal cover, so please don't be shy. And don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening to another episode of Diabetes Care on Air.